To eliminate malaria, we must include all populations. Tailored interventions are needed for those not reached by the healthcare system. In the Amazon, illegal gold miners are the primary hosts of malaria. They risk spreading the disease and developing drug resistance due to misuse of artemisinin, I hope I'm pronouncing it correctly, based combination therapies, ACTs. The miners' remote locations and regulatory challenges limit their access to healthcare. Now on to a moderator who does know how to pronounce these diseases. Please welcome Elodie Jambert, Executive Vice President at Medicines for Malaria Venture. Thank you.
Thank you so much, everyone, and thank you for being part of this really rich discussion today about malaria elimination and good practice from the field. And I'm really thrilled to be here, and I would like to thank the organizers of the Geneva Health Forum and our dear panelists who are here with us today, and I would like to invite them all to come on stage with me. I will start to very quickly introduce myself, and my name is Elodie Jambert, and I'm a Senior Director at Medicine for Malaria Venture, working in the Access and Product Management team. And I'm a pharmacist, I hold a degree in pharmacy, and I've been working in the last 25 years on access to essential medicines, and I've been working in the past with WHO and Doctors Without Borders, and now I'm working at Medicine for Malaria Venture. And as you may all know, MMV, so Medicine for Malaria Venture, was established exactly 25 years ago, and we are really proud today to celebrate our 25th anniversary. And MMV was really developed in 1999 and born out of the most greatest health inequities, which is really a lack of access to quality and affordable anti-malarial medicine. So MMV, as a product and development partnership organization, our goal is really to discover, develop, and deliver those new anti-malarial medicine that we are developing in partnership with a number of different partners. And over the past 25 years, we have developed 15 new medicine, and we estimate that those have saved more than 15 million lives so far. So it's really exciting, and we are really proud to be here today. And I'm just to really quickly wrap up this very quick introduction. My role at MMB has been really very much focusing on Varvax malaria and leading on access to tafenoquine. And for those who might not know, tafenoquine is a new drug that has been co-developed by both MMV and GSK in partnership. And it's a single-dose relapse prevention for Varvax malaria. And we are actually in the process of rolling out this new medicine together with a G6PD point-of-care diagnostic test, and we'll be talking about that later today. So this session today will really very much focus on real-world experience in introducing those new tools and strategies to tackle malaria control and elimination. And with our panel of experts, who I will very shortly introduce to you today, we aim to bring a very rich and insightful discussion, really fed by what we are learning on the ground. And we are all coming from that specific area of expertise, having worked at country level. And this is really the reality check that we wanted to bring in our discussion today. And as you know, there are really plenty of successes and reasons to be encouraged and really excited about what's coming up and all those new tools and strategies that are now available to countries to support them in reaching their malaria elimination goal. And so I hope that you will all come out of this session fully energized and full of optimism about all the opportunities that we have in front of us. However, I also would like to make sure that we also have the chance to discuss the difficulties and challenges that we are encountering on the ground, because we all know that it's not an easy task. There are many different difficulties, and I'm sure that all panelists will also talk about those in a minute. And then finally, we also want to emphasize the importance of developing partnership, not only on the financing front, but also on the implementation and research. And we believe that one of the most important partnerships is with local communities, and being able to reach the most vulnerable population who may not have access to those new tools or interventions. And we really strongly believe, I think we all share that same common belief, that we will not be able to reach a zero malaria case if we are not able to reach those most vulnerable population. And this is what we will be talking with our panelists today. So I will give the floor to each speaker in a minute, and then we will open up for discussion. And I will start by very quickly introducing each of them. And I will start by introducing Professor Marcus Laceda, who is an infectious disease physician who has been living and working in the Brazilian Amazon region for 24 years. So he's based in Manaus in Brazil. And he has dedicated his whole entire career conducting clinical trials, and especially on Varvax malaria and other tropical diseases. He has also led real-world study on the implementation of some of those new tools that I've mentioned, and supporting very closely the Brazilian Ministry of Health in the implementation of the point-of-care G6PD quantitative test and tafenoquine in the most remote area in the Amazon region, especially in the Yanomami, and I'm sure that you will be delighted to hear about that. Next, I would like to introduce Dr. Kevin Tete, who has joined FINDS in January 2023 as director of the Fever and Malaria program. Previously, Kevin was an associate professor of infection diseases at the London School of Hygiene and Tropical Medicine, and he has over 20 years of experience working in academia and in the biotech industry and with industrial partners. So he combined really his expertise with a passion for using innovative approach to help address healthcare concerns, and I'm sure he will be talking a lot about the new diagnostic tools that we are also have the opportunity to use today. Next, I'm delighted to introduce Dr. Lucas Molfino, who is MSF Swiss Deputy Medical Director. He's a medical doctor, specialist in internal medicine with a diploma in tropical medicine and hygiene from the Royal College of Physicians of London. And Lucas joined MSF in 2005 and has been working during the last years in different MSF programs all over the place, really, so in Southeast Asia, Africa, and the Middle East. Next, I would like to introduce Noela Kisoka, who is the team leader of a malaria project working with the Street Tropical and Public Health Institute in Tanzania since 2020. And she has a Bachelor of Science in Human Nutrition and a Master of Science in Health Informatics with more than 15 years of experience in public health, health commodity supply chain, system strengthening, and performance management. And last but not least, I'm delighted to introduce Dr. Petra Curry, who's the Global Director of Health and Care at IFRC headquarters in Geneva. And in her current role, she oversees the IFRC operational plan on global health security, health protection, and water, sanitation, and hygiene. She works with a network of 191 National Red Cross, Red Crescent societies on health preparedness, readiness, and emergency response plan. And Petra holds a doctorate degree in pharmacy. I love pharmacists, so no bias here, but I think it's great to have you here. And she completed a residency training at MGH, where she specialized in infectious diseases. She also earned a postgraduate certificate in quality, safety, leadership, and informatics from Harvard Medical School. So really delighted to have you all here with us today. Thank you so much for being here. And I will hand over to Marcus for some key remarks and introduction. Thank you so much.
Thanks, Elodie, and thanks for the forum, for the invitation, and for bringing me from South America, and to share with you some perspectives on malaria elimination, which is something that we have been tackling over the last decade. And Usually when I started my career as a physician, I started to go to meetings full of investigators, and they were so clever. They knew everything about everything. They published all the good papers. They knew how to do everything. So when all this elimination malaria plan restarted, in one of those meetings I've asked them, well, why don't we all go to the field and we eliminate malaria ourselves? We're so good. We know what to do. Everybody understands about diagnosis, treatment. We know PQ, we know everything. And it happens that if researchers, they go to the field to eliminate malaria, it's going to be a mess because they know nothing about the field. So they are very much used to perform studies in the best case scenario. And the best case scenario does not necessarily reflect what happens in the field. So if you're really going after elimination, the one thing to do is try to do a translation of what has been generated in the best case scenario, which are the clinical trials and the validation of tests, and what happens in the field. So because of tafenoquine, as Elodie mentioned, I got involved in the development of the first phase 2 and 3 clinical trial stages of this drug, and everything is very well controlled. You get the best patients. If the patient has any problem, you do not enroll them. Someone who lives close to the hospital because it's easier to do visits. If someone does not do a good job in your team, you just fire them. And it ends up that your clinical trial is beautiful and you show efficacy and you have a fancy paper in the New England Journal of Medicine or the Lancet. But then you get that paper and you take to your Ministry of Health, and it happens that there are things that they don't understand, and you got to say, oops, that was a mistake, the clinical trial. And then you have to make adaptations of the trial to the real life. So at the end, when you go to the field and you do implementation science, which is something very new to me, and I have been learning a lot because of that translation from the best case scenario to the worst case scenario, is that we were not quite clear on what we wanted when we did the clinical trial. And we have been repeating over time how much the clinical trials do not represent real life, and that's why we have nowadays the real life studies, because they actually give you another perspective. And you try as much as possible to replicate what happened in the clinical trial, but it happens that you have no control upon the patients, you have no control upon the diagnosis, you have no control upon the supplies. And that's probably something that we will have to do more professionally in the future if you really want to eliminate malaria. The generation of evidence is only one piece. But when it comes to the field, I think that having the people from the field since the very beginning getting involved in the clinical trials is very helpful, and it's something that we're not been doing. We have DSMBs, we have a bunch of good investigators who makes the committees who evaluate your trials, but we are not using the population to give their input on how that clinical trial should be done. So I think it's in this opening remarks, I would like to call the attention to everybody that if you stop before implementation, you probably are not aware of the many challenges that you have to make an implementation, especially if you have big countries with different cultural perspectives. That happened, for example, with retocaps, which is the intrarectal artesunate, that was very well accepted in some places in Africa, but in South America, for reasons of the macho man, it was not possible to use intrarectal drugs, and that was never thought since the very beginning. So sometimes you lose a lot of time and effort trying to believe that people will accept your product just because you made it in the best way, and that's not the case. Thank you.
Thank you so much, Marcus. Yeah, it's really great to talk about the need to and importance of real-life studies, and really to move from the best case scenario, as you said, to the worst case scenario, and really the work that you have done with the feasibility study in Brazil around the use of those new tools in real-world practice, really, and looking at all the challenges and lessons learned for the future implementation of those new tools is really critical, I think, and really extremely important for Ministry of Health to really better understand how to adapt those tools which are coming out of very strict and controlled clinical trials into the field. So yes, that's really important. And I'm going to move to Kevin. Give you the floor.
Thank you. I'd just like to say thank you to the organisers for inviting me and giving me the opportunity to talk, and to the rest of the panel. I think this is going to be fun. So I'm going to pick up from Marcus's worst case scenario and sort of pick on my favourite topic. And when we talk about malaria elimination, it's going to be climate change. And when we talk about climate change, we're really talking about climate crisis, which is in fact a health crisis. And so when you're thinking about elimination and find we're a diagnostics entity, a health system strengthening, we have to think about what impact that's going to have in our ability to deliver those interventions that we need. So the fact that, I mean, we already know that there's going to be increased risk. The regions are impacted are going to be wider. There were some sessions earlier on this morning and yesterday talking about malaria in Italy, malaria in the US. So it's re-emerging in areas which used to have a huge malaria problem, and for a long time it was gone, now it's coming back. So I guess the thing I would like to focus on is really trying to think about when we start to try and think about how we address these concerns, how we try and develop new tools to get into these spaces, we also need to be thinking, and at FIND this is what we're doing, is trying to mitigate against those tools, to give those tools the longevity that they need. We have to think about what the impact of the climate, what impact climate is going to have on those tools. An example is when we take the tools out into the field, to take Marcus's point about having tested your devices in a controlled situation, we do a lot of evaluation, a lot of field evaluation to try and determine how well those diagnostics work in the field. And one of the things that we find is that temperature is a big problem. Most of the IFUs, or the instructions for use, will tell you it will run from, 4 degrees up to about 25 degrees, maybe 30 degrees. But in most settings that you're going to need those tools, the temperature is far greater. So immediately you're in a situation where you know that the longevity of the device is impacted, the efficacy of the device is impacted. So those are the type of things that we need to think about, and we're constantly trying to address when we think about taking tools into the field, and of course the elimination question. The other point I'd like to raise is the fact that actually when we're talking about bringing tools to the field, what we're really thinking about is, and in Geneva, so this is a good example, is 4 legs of a chair. Right, you take one of those legs away, then you've got an unstable component. So we need diagnostics, we need drugs, we need control measures, and now we have not 1 but 2 vaccines. The vaccine doesn't work particularly well, but the best thing it's done is shown that we can do it, that you can deliver a vaccine against a very complicated parasite. And so now the floodgates have opened, and there's a lot that we can do in this space. The other thing I'd like to touch on is the fact that climate change is driving a lot of diseases, not just having an impact on malaria. It's very complex. We don't know exactly what it's doing, how it's impacting. We know it's driving things in terms of dengue in South America and also in Europe. We know it's having an impact through data that we see from places like Pakistan. But there are still significant gaps. So what we do need is innovative tools. We need innovative tools. We need to be thinking quite broadly about how we bring those tools to the primary health care, to the community health workers, and to the community. One of the things we'd really like to do is to engage with youth groups to make sure that any new tools that come on board have a real chance of being taken on board by being accepted by the community. So there's a real urgent need in terms of where we go forward, in terms of the type of innovation that we need. We need to try and think beyond the tools we have at the moment and how we might be able to use them in concert with the other tools that we have, drugs, vaccines, etc. And I think, neither one of them is going to do the job. We know that. There's some incredible drugs out there, but resistance is huge. In terms of control, there's resistance to the mosquito, is also got resistance to the impregnated nets. So in order for those to be able to deliver, in an elimination setting, we need to really bring those 4 together so that they work in concert. I'm trying to keep track of my time because I do have a tendency to roll. So in that setting, we really do have an urgent need for true point of care, preferably molecular tools that we can engage in this setting. Because as the complexities of climate change roll on, the needs in each country is going to be very different. One thing I really should talk about when I talk about the needs is partnerships, and that's a big thing for FIND. We do all the work we do, and we're successful in the way that we are only because of the partnerships that we have, both in terms of the funders, but also in terms of our partners in country. And having a true understanding, a real understanding of what the needs are in country is what helps us to be able to deliver what we need to in the real world setting. So when it comes to elimination, I guess my talking points are really trying to, the need for a real advocacy in terms of climate change and the true world impact it has on everything that we're trying to do, and trying to think of real ways that we can adapt and mitigate against what's coming. I think I'll pause there. Thank you, Elodie.
Thank you so much, Kevin, and really great to hear, that it's so important to understand what are the real needs coming from country, because I think this should really be the starting point for everything. And very much appreciate the focus on the impact that climate change may have on many different aspects, as you have just mentioned, in terms of not only from an epidemiological perspective, but also, such as very practical things in terms of, the temperature, the impact that increased temperature will have on the use of new diagnostic tools, for example, and obviously that's also the same for many other tools that we're using, drugs and etc. So very insightful comment. Thank you so much. Lucas, I'm going to turn over to you.
Yeah, thank you. Good afternoon, everybody. So, well, first of all, thank you for the organization, thank you for the panel. I think that I keep the line on trying to maintain the field reality, attached to the field reality. I think that I would like to, as a MSF, to bring our experience of what we are seeing in the field, in the different settings that we are working. And what we are seeing is that malaria still is responsible for an acceptable high number of deaths, especially for a disease that is preventable and curable. I think that the high burden of the disease is in areas that people still challenged to have access to healthcare, and we are talking about very vulnerable populations. Has been said, a lot of tools, a lot of innovations has been developed in the recent year, from new drugs, vaccines, improvement in the testing, different prevention strategy. But I would like to insist, we would like to insist as an organization in the core message that no one single available malaria tool will be able to solve the malaria problem. The different tools need to be combined and implemented next to each other. And vaccination, as we were discussing this morning, is one part of them. From our field experience, all the tools and the available strategies are still far to be implemented in an optimal way. So you can pick your example. But from vector control, for example, we see a very low coverage of mosquito net or indoor residual spraying. We see a lot of rupture of stock and the supply chains from diagnosis, rapid tests, and treatment. People still have challenging to access to blood banks and blood transfusion, especially in remote settings with IDP, refugee camps, these type of things. So that is remain a challenge. The preventive strategies are far to be implemented with the seasonal malaria chemoprophylaxis, the MDA, and all the prevention of malaria in pregnant women. But also we would like to share a good example, because positive experiences are coming from the field as well. Especially the one that we would like to share is the implementation of the Mass Drug Administration, MDA, as a rapid tool to a quickly reduction of malaria morbidity and mortality in emergency settings, as is recommended by WHO. So I want to contextualize this. In 2020, COVID, Ituri province in DRC, in Angumu, so highly malaria endemic area, massive display of population, heavy rains at that time, that year, and well, and the MSF team in the ground, they were witnesses a high mortality rate due to the malaria, anemia, and other things. But in that complex, in that situation, in a complex humanitarian crisis, with population moving, with highly mortality, with limited access to healthcare, I think that in the midst of the COVID, I think that the MDA was seeing a reasonable things to discuss, with the aim to reduce mortality and morbidity, and especially in the short-term impact. So We did it. I think that following the WHO recommendation in different areas, 3 rounds of ACTs, 3 days course. The interesting thing is that the first 2 rounds were artesunate amodiaquine, but the last round was using the new drugs, the Piramax. That was quite interesting. Huge preparation, very logistical preparation was a door-to-door strategy at that time, so huge number of field teams with community health workers doing that. And we documented properly the coverage and the impact on the acute mortality rate and the mortality rate under 5. So the result was a very good coverage in the village, in the IDP camps, and a lot of adherence, and the people were quite happy about the Piramax in the way that they were not producing side effects, so they were quite something to remark. And after that, we repeat the intervention in 2021 and 2022, and we noticed, so that the reduction on the mortality. The second and the third round were combining with other measures, as we were discussing before, with the improvement and enhancing of the routine care and the use of indoor residual spray. And our conclusions are that the MDA is feasible to do it at a large scale. I think that we see the effect in the short term, especially in the under 5 mortality and morbidity. And when we combine with other tools, the effect on the malaria prevalence seems to be decreasing with combining with other tools. People will love it, and the report that we have is that people were loving to have a period of time without malaria. People can go to work, kids can go to school. I think that there was something remarkable of the consequence of this intervention. And yes, it's a tool that is feasible to implement in complex humanitarian setting with high malaria burden. I think that can be part of the package of malaria control. We replicated the experience with all the lessons learned in South Sudan, in the north of South Sudan. I think that the next challenge is hopefully this year in Angumu, we are also going to combine the malaria vaccine as well. So that's all.
Excellent. Thank you so much, Lucas. And really important, I think, to remind us all about, this huge mortality that we are still facing today. I mean, 600,000 children dying every year is just frightening. I mean, for me, sometimes it's just difficult to realize that despite all those good tools that we have currently available, so many kids are still dying every day. And at the same time, it's still very positive to hear that, such practical strategy, which is 3 rounds of MDA, can actually decrease that mortality, and the success of your MDA and the high coverage that you have mentioned is very, I don't know, it's somehow reassuring. And also, I think that you have illustrated very well, the importance of combining all those different tools, because I think that we all agree that, one tool will never do the job. We definitely need to combine different interventions, different tools, and I think that you have really greatly show that, combining MDA, which is a new intervention, with, for example, indoor residual spraying can really make a huge difference, and is also very well accepted by the community, which is equally important. So both aspects are really fascinating to hear. So thank you so much. And with that, I would like to hand over to Noela. Thank you so much.
Thank you, Lodi. I would like first to appreciate this opportunity and the invitation that I got from the coordination team to come and share the experience of field specifically in relation to malaria elimination. I come from Tanzania. I'm going to share the experience of Tanzania, but not just Tanzania, but the entire sub-Saharan African countries. So I'm representing my brothers and sisters back home in Africa. So I'd like first to start by saying malaria is one of the luckiest diseases. And the reason why I'm saying it's one of the luckiest diseases is because it has received a lot of attraction from different partners, the experts, and different academia in terms of providing the technical how on how best is it to control and eliminate the disease in the continent. For a number of years, I would say we've had a stable finance in the countries, specifically the sub-Saharan African countries, We've had a stable stable funding capacity. And I would say at the beginning, we had a massive gains from that. But the past 8 to 10 years, with the same funding levels that we have had in the past, the situation is not really going down. We've had a plateau of burden of the malaria disease in our countries. And if you go down and dig into the data for every sub-Saharan African country, you would see that definitely there's either an increase of morbidity or increase of mortality. So what I'd like to say is getting on the reality on the ground specifically. The countries are doing a lot. They have great strategic plans. They have plans that are very creative, very much innovative plans, but unfortunately those plans are not funded, or the innovation has not been optimized to 100%. And this is mainly due to inadequate resources. When we talk about elimination, definitely it's not an easy task, especially when you're talking about elimination in African countries with very low low and medium socioeconomic income. Francesca, in the afternoon, in the morning, she mentioned that and some of the speakers, it's a disease of poverty, and poverty is there. So yes, we had at the beginning challenges of having treatments. We had at the beginning challenge of having the diagnostic tools and all that. Right now, that is no longer a challenge. Availability of commodities is good. The diagnostic tools is as well good. The only challenge that we are having is trying to venture on the new tool, implementation of the new tools, and to bring in innovation. So basically, I would like to say those are the main challenges that these countries we are facing. And the question that we need to ask ourselves is it worth investing a lot of money for a number of years without having significant gains? Is it high time to look and reflect back and see how best is it that we can, I understand the challenges of resources, but how best is it that such countries can be looked at in a different angle and see how best to reprogram and re-strategize our intervention so that all those that the countries feel and think they would bring malaria down should be supported. Unfortunately, they are not supported because either they are not in the appetite of the people who are currently providing the support, but also due to limited funding, and the priorities are going to commodities and treated nets and things like that. So those are a few, but I would like to as well agree to my previous panelists that climate change has been a great deal. We've experienced rains in periods when we are not supposed to be having rains. And we used to think malaria was a seasonality thing, but right now really that has not been the case from last year to date. We've had rains from last year up to just the past 2 to 3 weeks. That's when the rains stopped. So that means even the burden of disease tends to be increasing due to rainfalls. So I'd like to pause here and over to you. Thank you.
Thanks.